Today we're going to be starting our last chapter of the semester. So we're doing chapter 16, which is all about our treatment of psychological disorders. Now, we talked a lot about our disorders in the last chapter. That was the whole point of that chapter. And now we're saying, okay, of some of those treatment types that we might have mentioned tangentially, can we dig into this a little bit deeper? What are some of our alternatives? What are some approaches that we generally see? And this is going to end up including a little bit of history and a little bit of how that's progressed into more modern approaches. But as per usual, it's sort of an overview and not meant to be an exhaustive discussion on the topic, more so just an introduction to what there is out there to learn about. And so our first step is going to get into the elements of the treatment process. Basically, how do people seek treatment and what are kind of the things we consider when looking at treatment? And then we'll get into some of the different types of treatments and again, so on and so forth. So baby steps to start. What is our treatment process? And this is just saying, okay, well, let's look at the relationship between our client and our therapist and the technique that they're using and our goal outcome. So we can ask some questions about things like, what is the goal of this treatment? Mainly, if we simplify it, we're saying, okay, we want to change some maladaptive thoughts or maladaptive feelings or maladaptive behaviors and have this person then be able to think and feel and behave in a way that's healthier or that's less disruptive or that makes them feel more comfortable or something like that. This has also introduced the concepts or the terms for the client being the person who is seeking treatment and the therapist as the person who is carrying out that treatment. We will see that therapists can have very different roles depending on sort of what type of therapies or what type of treatments we're looking at. And that's sort of represented here with our therapeutic techniques or therapy techniques, which is saying, okay, well, how do these individuals work together? What is the nature of that relationship? We'll see that in some cases, Freud will mention things like the therapist being in charge and telling you how to think and behave. Or we might get something that's a little bit closer to Rogers, where we have more of an equal footing as you discuss things as equals and work together to find solutions. So that nature of that relationship can change dramatically. We'll also start seeing that there's a lot of differences in the clients themselves and who decides that they want to seek therapy, who wants to pursue treatment. And so some of the most common issues that people will have when they decide to seek out therapy is going to be anxiety and or depression. So some of our reports would say that, say, 15% or so of the US population makes use of mental health services, and the vast majority of them are going to be there for anxiety and depression treatment. We do find, as we've said, those two tend to be fairly comorbid, so we do often see them co-occurring when people are seeking treatment for those. We do also see a lot of differences in terms of the sexes. So women are much more likely to seek help than men. People with higher education levels will also seek treatment more often, though that could be one of those correlations that has other explanations behind it, where things like higher education tend to correlate with greater wealth or with better paying jobs or things that would basically give them health coverage and or the ability to pay for therapy, which can be expensive depending on where in the world you are. So those sorts of things definitely play a role here. We do know that a lot of people who might need help don't end up seeking treatment. So there can be very long delays between the start of symptoms to the point that they seek assistance. And oftentimes it's basically because they might wait until the symptoms are problems, or I guess troublesome or causing problems is the better way to say that. And in those cases, they'd start seeking therapy once it's gotten to the point they can't manage anymore, instead of starting when the symptoms were lesser and might actually have responded to treatment a little bit better. We do also see that there are many people who probably should go for treatment, but won't go for treatment for, say, cultural reasons or personal reasons or inability due to financial or accessibility reasons or whatever it is. There's a whole bunch of different factors that we can discuss. And we will end up talking about some of these other concepts as we move throughout the chapter. We'll look at some differences in willingness to seek treatment. I think we have a whole section towards the end of the chapter where we talk about cultural differences and we talk about sex differences, where depending on where you are in the world and your sex, you might be more or less likely to seek treatment. But there's, again, a whole bunch of other factors that might play a role there as well. But continuing with the overview, for our different resources that are available, there's a lot of different places that people can go to seek help. So it isn't just therapists, it isn't just psychologists. There's a whole bunch of different titles and a whole bunch of different roles that can take on this sort of therapeutic role. So of course we can have psychologists and psychiatrists. So specifically, if we have counseling and clinical psychologists, they typically have a PhD and at least 5 years of training in the therapeutic or psychotherapeutic techniques that they use. They might also be trained in research or psychological assessment techniques. So these are individuals who have trained for that specific role. Alberta is actually an interesting case. There's been a lot of discussion lately because presently within Alberta, you don't technically need a PhD to be a practicing clinical psychologist. Here, you can do so with just a master's, but if you transfer anywhere else in the country, then you need to upgrade and get the PhD to qualify. And there's been a lot of debate of them changing that, where they want to increase it to match the rest of the country, but I haven't really been following the debate because that seems to pop up every sort of 3 years or so is about this cycle. So we'll probably hear about it again in the next year or so, just from my memory. But that's one of those ongoing issues where different places, even within a country, can have different regulations on what you need to fulfill that role. Psychiatrists are typically going to have more of a medical component as well. So psychiatrists would also be able to, say, prescribe medication, which not all psychologists are able to do. So there's a slight difference in the roles there. We can sometimes have, say, psychiatric social workers, so people who are more focused on working within groups or social groups specifically. We can have marriage and family counselors, so they would focus on family relationships and trying to mitigate disagreements and things in that sort of a role. Pastoral counselors can work with spiritual matters if that's what someone is seeking. And there can be abuse counselors who are specifically specialized for substance abuse and things in that category. So this is just sort of a subset of all of these roles. There are additional specialties, but these are some of the really common ones. And so when people are seeking help, there are typically a bunch of different directions that they can go in. So they might choose to go to a health practitioner if they need a prescription, which then might get them referred to a psychiatrist, someone who is trained to both evaluate and prescribe, or maybe it just happens at the level of the family doctor. It's very flexible and it depends a lot on the situation that each individual is in. But if we start looking at different kinds of treatment types, we're going to touch quite a bit on sort of 3 broad categories. The first of our categories will be our insight therapies, which are sometimes also called talk therapies, where we'll look at sitting down and having a conversation with your therapist, sort of whatever their title is. So mostly we're going to cover a bunch of different perspectives. We'll go through some of our cognitive perspectives, all the way to our psychoanalytic perspectives and everything kind of in between. We'll then talk about our behavior therapies, where we're trying to change those overt or expressed behaviors. So we'll get into maybe some behavior modification, stuff that lines up with that behavioral perspective we've talked about repeatedly throughout the semester. And then towards the end, we'll talk about some of our biomedical therapies, where we can look at medications that might be helping to manage symptoms and how those might work. So a whole bunch of broad categories to look at. And then just to help us sort of sort these under the different perspectives that we might have, we can see our psychodynamic perspective, our humanistic perspective, and our cognitive perspective. Those are all going to be mostly under that umbrella of talk therapies, because it's usually the client and the therapist having a conversation and changing how they think about things. But we'll go into each of those on their own. The behavioral therapy and the biology therapies, those are the other 2 categories. So the first 3 are kind of one umbrella, and the other 2 go on their own. But this is a pretty good overview of all the topics we're going to talk about today. So if we start at the beginning with our psychodynamic therapies, as soon as we start seeing the term psychodynamic, we should start thinking Freud, because that's where this is originating from. So it's based on Freudian principles. So our psychodynamic approach is focusing a lot on our internal conflicts, our unconscious factors that are underlying our maladaptive behaviors. So we are focusing in on stuff that we are probably not consciously aware of. This is all the stuff going on under the surface, and how those different factors that we're not aware of are driving some of our behaviors that we don't want to be there. So one of the goals, or the main goal for these kinds of therapies, is to help the patients achieve insight. And so insight is basically, we want them to have a conscious awareness of those psychodynamic things that are underlying their problems. Basically, the therapist is supposed to enlighten the client and be like, here is what's driving your behavior. Here's the thing that you're not allowing yourself to be aware of. Here's that deep, dark urge. Here's that unconscious process. And now that you're aware of it, let's see if we can adjust that situation to get rid of those bad behaviors that you no longer want. So a lot of this will tie into, as per usual with Freud, we're looking at aggression and sexual urges, and typically with a focus on stuff that's happened in the past. Freud was very focused on traumas that would have happened in childhood that would then create a lot of these underlying problems that are sort of manifesting in current behaviors. So he would focus backwards very, very commonly. And so if we start getting into some of his ideas, some of the processes he'd be using, he really, really liked the process of free association. Basically, if you've ever seen the game of I'll say a word and you have to say the first thing that pops into your mind, that's free association. So it is an uncensored conversation where you're going to say whatever pops into your head. So the therapist might prompt you to get started, they might say something, and the idea being that the first thing that hops into your head is a concept that's related to whatever the topic is. And the goal for this is to try and get people to start talking about the things that they might not want to be admitting, that they might be trying to push down and hide away in their unconscious. And from this, as they get closer and closer to stuff that's causing distress, that's sort of the source of the problems, they might start getting some pushback. They might start getting agitated or sort of avoiding the things that pop into their minds. And for Freud, that would be an indicator that he's on the right path. So this can include thoughts and feelings or images that pop into your mind. And again, we're focusing on that without censorship. So trying to encourage the clients not to hold anything back, because holding stuff back is actually the root of the problems, at least according to Freud. We also know that Freud was big into dream interpretation. So Freud thought that our dreams were basically our wish fulfillment, where when we were asleep, our strong control of our consciousness would relax a little bit, and we'd create dreams as sort of a safe environment where all of those hidden deep dark urges that were being suppressed during the day could be let out and released in a way that doesn't actually affect the real world. So if that's what Freud thought, then interpreting and sort of listening to what people were dreaming about might then give some insight into the stuff that they were trying to keep at bay during the day. So when you see all of the books that are published nowadays where they talk about, oh, this imagery means this thing. One of the ones that always sticks out to me is that when you dream of your teeth falling out, that's a feeling, or you're feeling that you've lost control in your life. That would be one of those things that came from Freud. And so that has kind of taken off and has become a lot more popular. But it's one of those new interpretations of something that started with Freud and his psychodynamic theories. But in this case, the goal is for the therapist to help the client understand that symbolic meaning behind the dreams. So sometimes it wouldn't be a direct interpretation. It might not be the surface level information. It might actually be the hidden stuff underneath.
And both would be important. So they might interpret what's actually happening, but then they'd also get the symbolic meaning that's driving it sort of from the unconscious. So yeah, there was a lot of different things. And he might combine the two, where he could use free association, where he'd get you to say the first thing that popped into your head about some of the topics in your dream. So if you were dreaming about a train, what's the first thing that pops into your mind when you think of trains? Well, that might be part of the symbolism. So very abstract concepts. Now, within this sort of psychodynamic perspective, as we get into some of this psychoanalysis of people's personalities and how they're acting and why they're acting that way, he really focused on resistance. And so resistance is, or refers to our defensive maneuvers that people would engage in to try and hinder the process of therapy. Basically, when people started resisting and holding back, so maybe during that free association, they don't want to say what popped into their mind. Like I said, that was a clue that they were on the right track. And if the person didn't want to share that information, they'd label it as resistance. So it's a sign that we're starting to approach that anxiety arousing material. And if it's something that's intense enough to bring about anxiety, then it's probably involved in, or at least the root of, some of the behaviors that you're interested in. Another interesting concept that went along with this was the idea of transference. And this is where they would see that sometimes clients respond irrationally to the therapist. So sometimes if you're thinking about somebody that you really, really like, or you really, really dislike, they would transfer or transplant those feelings onto the therapist that they're talking with. So because they've been talking about interacting with someone they hate, they might start feeling like they hate their therapist. And so the clients might be confused. They're like, I'm not quite sure why I feel this strong dislike of you, but I really, really do. So they called it transference. And it's basically bringing out those repressed feelings, the stuff that you've been shoving down for that individual you dislike, and bringing them up and applying them to whoever's around when you are doing that work. So it should, as you get closer and closer to those feelings, help you start understanding some of those maladaptive behaviors theoretically. And with that transference, I've already kind of mentioned it, so it could be someone you really like or someone you really dislike. They have different categories. They'll call it positive and negative transference. So positive can be feelings of affection, dependency, and love, whereas negative would be anger, hatred, and disappointment. So positive and negative emotions. And both can happen in terms of transference. All right, another thing that comes up, or another one of those terms that's common with psychoanalysis, is interpretation. And this is something that people try, and, or I guess we'll start seeing that they start getting away from some of this a little bit. But they were really common with interpretation in these situations where the therapist would make particular statements to try and push the client to thinking a particular way. We'll start seeing that the later therapies start focusing on not so much directing and pointing them in the right direction, but allowing them to reach their own conclusions, kind of forcing them to think logically about stuff. But with our initial psychodynamic perspective, we start seeing that they're providing the client with insight into their behavior. This is what it is, this is how you're feeling, and this is why you're feeling it. This is actually one of the reasons why there were some issues with these psychoanalytic approaches, because they were making people think a particular way or making them remember particular things, and it may or may not have been accurate. So it can cause some problems. This interpretation, so especially if they're trying not to make some of those declarative statements, and if they're not trying to sort of push them too hard, it can take some time to get the patient to that point of insight, especially if they're resisting the therapist's statements. So if we have to wait for the client to have their aha moment where it finally clicks for them, they might resist this push by the therapist, and that might be one of the reasons why these psychodynamic theories or therapies, end up taking so long. And in fact, if you actually look at the original work by Freud, when we talk about long-term therapy, we mean long-term therapy. With some of his early patients, he would meet with people multiple days a week, sometimes as many as 5 days a week, and he would meet them every week for multiple years. Some of these patients would be with him for 5 or more years. So there would be hundreds and hundreds of sessions. And it kind of makes sense, because if we go back to what Freud's original motivations were, he was really, really concerned with completely changing individuals' personalities. Because we've touched on Freud and this psychoanalytic approach when we were looking at how he thought of personality and how that affected consciousness and how it was all kind of one big concept. This isn't any different. He wanted to understand people's personalities, to understand their motivation for behaviors, so that he could then change their personalities to change those behaviors. And to get all that information and to have such a large scale change to how a person acted, it would of course take very long periods of time. However, most people seeking out therapy, that's not really viable. Not everyone can afford going every day or most days for multiple years at a time. And that's where we started seeing a push for much shorter durations. And there's been a lot of studies that are saying, okay, well, if that was sort of the ideal when Freud first proposed it, how short can we make this? How brief can we get these exposures and still see benefit? And that's where we get into our aptly named brief psychodynamic therapies, which we're basically saying, okay, what's the bare minimum? How few sessions can we get and still see an improvement? And in order to do this, we had to shift from Freud's original idea of understanding someone's personality in its entirety and fixing it in its entirety, and instead start focusing on what are the individual issues and how can we fix these small issues. So we changed the scope and the scale, and actually found that with that shift, we start seeing about the maximum improvement in as few as 10 sessions. So this diagram is actually from a meta-analysis, meaning that they looked at a bunch of different studies and collapsed the data to see what the trend would be. And typically, this is an improvement. So OQ45 is just the name of one of their standardized tests. And they were measuring sort of a distress measure. So when they started, they were in lots of distress, and they started to see improvement. And then we see that the lowest point is in that sort of 10 to 12 session range. And then any longer than that, there's sort of a rebound there a little bit, but that's a pretty flat line, saying that we'd see the most improvement in the first 10 sessions or so, and then anything beyond that isn't necessarily going to get you any better. So they could use studies like this to say, hey, our shift from our long-term to short-term focus, from broad scale to small scale, we ended up seeing a significant improvement. And this is about how long it takes for that to happen. This is probably one of the reasons why different programs will have limits on the number of sessions they can offer, usually in the 10 to 15 session range. It would be studies like this that show that that's about the maximum amount of benefit you can get. So this is why we think that our shorter therapies are beneficial and can have merit. It's definitely going to be more economical, so it's less expensive for the individual seeking therapy because they're not going 5 days a week for multiple weeks of the year. And we're able to focus on those specific maladaptive past influences. What events are leading to this? What bad behaviors or maladaptive behaviors do we care about? So we're focusing on only what matters and kind of ignoring the rest. So yeah, this was kind of like the psychoanalytic perspective, but focused in on the most important stuff to get the maximum benefit from it. But when we get into sort of our interpersonal therapies, this is a subtype of our psychodynamic therapies. This is specifically using that same psychodynamic approach, but specifically to focus on relationships between individuals. So how is this client interacting with their spouse or their parents or their children, and applying it sort of in that particular focus. And because it's specifically looking at those interpersonal relationships, it gets its own fancy title. And that's one of the major problems that people have issues with. So you might be depressed because you're having poor interactions with your spouse or with your parents. And so maybe we can alleviate some of those symptoms by addressing the interaction between those individuals and maybe helping improve that situation and then affect the other things that drove you to therapy. But yeah, not too much on that because we get to launch straight from that into our humanistic psychotherapies. And so every time we move from psychodynamic to humanistic, we are usually reminded of the history that leads to these two almost always being considered back to back, where our psychodynamic perspective, we've been focused a lot on the past and the unconscious, stuff that happened previously that's influencing our behaviors now, but we're not aware of those processes. And we had mentioned that a lot of Freud's ideas were focused on very pessimistic interpretations. So there's a lot of the sex and aggression and trauma in the childhood, and a lot of sort of dark framings of the human condition. And so our humanistic perspectives were really focused on shifting away from that. So most of these are coming on the heels of the surge in the psychoanalytic therapies. And so they wanted to start focusing on, okay, it's not just the unconscious. We want to focus on conscious control of behavior. So we want to be able to take control of our own actions, and we're going to be more focused on the positive aspects of what it means to be human. So we can have personal responsibility. What is each individual in charge of? What are they doing with their lives? And of course, all of this is usually trying to look at the role or what's influencing our disordered behavior. So a lot of this comes down to things like distorted perceptions. So people have framed things in an incorrect way. This will be something that carries over into our cognitive perspectives as well, but we talked about this in relation to things like depression, where people might be framing their interactions with the world in a way that they feel responsible for everything that's bad, and anything that's good is coming from an external source that would fall under this category. So we might also look at things like their lack of awareness. So maybe they're not thinking about things from somebody else's perspective and that's causing tension, or maybe they're not aware of something that's causing them distress. So giving them that insight and adjusting a negative self-image. So all of these would go together. And so when we talk about our humanistic psychotherapies, one of the most famous of these actually comes from Carl Rogers, who's one of the big names that we always mention when we talk about our humanistic therapies. Usually we talk about Rogers and we talk about Maslow. Maslow with his hierarchy of needs, and Rogers is all about client-centered or person-centered therapy. And this was that big shift as we went from our psychodynamic perspective into our humanistic perspective, because when we had Freud's view, it was a lot of our therapist is the person in charge. They're the person in control. They can make statements and guide you and tell you what you should be thinking and how you should be thinking. And the client is there to listen and to follow orders and to do what they're told. So it's a very hierarchical arrangement. But Rogers was really focused on the environment that was being created and really wanted to focus on a meeting of equals, where the role of the therapist wasn't to direct you or to tell you what to do, but was more to provide a safe environment where you felt like you could be who you were supposed to be, where you could share bits and pieces of yourself in a non-judgmental space and feel comfortable to start changing how you think about yourself and your environment. So this is a really important shift because now we're meeting as equals, and it's a focus on a positive interaction as opposed to a directions and hierarchical arrangement. So within this arrangement, with this environment, when we're focused on the relationship between the therapist and the client, Rogers pointed to three key sort of components that he thought were essential to this situation in order to create that non-judgmental space. The first of these is the concept of unconditional positive regard. So the therapist should accept the client without judgment or evaluation, making the client feel like they can share information without having somebody think poorly of them. So if they're not being judged, if they have this unconditional positive regard, they feel safe to share. This ties into some of those important factors that we had mentioned for things in development, where children who are given that unconditional positive regard are more open and have better relationships because of that unconditional positive regard. So he borrowed the same concept and brought it into this environment as well. He also thought that empathy was really important, where the therapist should try and view the world through the client's eyes and make them feel heard and understood. So I understand that you are feeling this way for this reason. That must be awful, or that must be amazing. So having somebody who can connect with you, who you can share with and feel accepted by. And the last component is genuineness. So we want a consistency between the therapist's feelings and behaviors. So we want them to give you that support, to listen to you, and to give you sort of a genuine reaction. So they should feel and act in that supportive way. And so if we have all of these, if you can hit that sort of perfect combination, that should be creating that safe environment where the client feels like they can share and grow and change without judgment or fear or anything like that that might impede their recovery. And if we start looking at research that investigates, well, is this actually important? There is quite a bit of support that the therapist's qualities, if they can sort of tick all of these boxes, it seems to influence the outcome of the therapy. Where if the client feels like they are held in positive regard, where their therapist is empathetic and genuine, they're usually more likely to improve because of that positive relationship with their therapist. And in fact, we actually can see in some studies where it's beneficial, where if you don't connect with the first therapist that you interact with, it might be beneficial to try someone else. Maybe the first therapist you meet with doesn't click with you. They don't use the right words, or they don't understand you, or they don't feel right. Finding somebody else who meets these criteria for you might be more beneficial for your recovery, depending on the situation. Another type of humanistic therapy is actually Gestalt therapy. This is another one of those concepts that kind of comes up a couple of times throughout 104 and 105, but you might remember that when we talked about Gestalts, specifically Gestalt perception and Gestalt psychology back in the sensation and perception chapter of 104, if you have taken it, where we're basically talking about looking at the individual components that make up the whole. So the idea that we organize things together in a way that the whole can be more than the sum of the parts, where we tend to put things together in a particular way. And so they apply that same idea here, where they're focusing on making the client whole by focusing on these individual components and making a cohesive whole at the end. So they want to focus on feelings and wishes and thoughts that the client might not be aware of, bringing that into conscious awareness so that we can have sort of this unified moving forward motion where the client knows what they want and they can start moving in the direction of achieving that. This was an interesting type of therapy, and in fact, it doesn't so much exist as a standalone anymore, but some of the individual aspects used within it have been carried over and borrowed in other perspectives. So it's kind of shared among different areas nowadays. But often it's carried out in groups so that you'd have sort of one therapist with a bunch of different clients, and that way they can help each other and sort of work together. This is a lot more active and dynamic than some of the other client-centered approaches. So instead of just a nice back and forth conversation between the client and the therapist, this would be a lot more interactive and maybe even aggressive, because a lot of the techniques actually ask the client to, say, put themselves in the shoes of somebody they're having conflict with, or someone who they don't get along with. And they would then argue both perspectives. So they would argue as themselves, and maybe they're having problems with their partner. So they would put themselves in their own shoes, but also in their partner's shoes. So they had role play. And specifically, one of the techniques is called the empty chair technique, which is where you carry on a conversation with a physical chair as though it was occupied by the person that you're having the argument with. and you'd think of what both of you would say in that theoretical argument to work through your different issues. And the hope being that if you're thinking of things from that person's perspective, it might help you realize their own motivations and what might be driving their behavior, and it might help you feel more sort of empathetic towards them. So it can help resolve some of the issues in that relationship that you might not be addressing by forcing you to think of things from another perspective. This empty chair technique does get used in a bunch of other approaches nowadays, but it did start here with our Gestalt therapies. Our next section are our cognitive therapies. For cognitive perspectives, if we remember, a cognitive perspective is this is when we started to shift to the focus on our internal conscious processes. What are people thinking? How are they thinking? And why are they thinking that way? So we're sort of completing that shift away from our starting point at the unconscious, and now we're focusing on intentional conscious processes. And so some of our big names here are Aaron Beck and Albert Ellis. Beck and Ellis were some of our big roles in terms of our different types of cognitive therapies here. And they really, really wanted to focus on basically fixing negative thought patterns. So again, we had mentioned, especially when it comes to things like depression, where we can fall into these negative thought patterns, where it sets us up to perpetuate a current ongoing maladaptive behavior. So individuals with depression are more likely to have that sort of negative worldview. They think poorly about themselves. They think poorly about their environment. They don't take credit for their successes. They take the blame for their failures. And all of those sort of patterns set them up to get depressed and stay depressed in that sort of cycle of depression. And so for these cognitive therapies, a lot of it would be focusing on saying, okay, well, is that an adaptive way of thinking, or is there a better way to be thinking about these things? So these would, the therapists here would want to challenge some of those negative thought patterns and say, okay, logically, what's actually happening? And how do you know that what you think is happening is what's actually happening? And so by challenging some of those thoughts and forcing them to think logically, we can start shifting some of those patterns into something more healthy and more accurate. And that's the main goal here. So one of the first steps is actually helping clients discover those problems, those cognitive framings, because you might not realize that you tend to think a particular way when you encounter certain situations. So step one is, what is the thought process that leads you to feel the way that you do right now? What makes you feel low when this happens? Okay, well, why do you feel that way? Why do you think that way? And is there a more logical way to think? So once we've discovered those negative cognitive patterns, then we can start focusing on changing them, again, mostly through logic and reasoning. So the first of our therapies here is the rational emotive therapy. And so this comes from Albert Ellis, and this is sometimes also called the ABCD model, which is nice and simple to remember. Specifically because we're looking at these four different concepts and how they relate to one another. So we start off with our activating event. So something occurs and it starts a particular situation. So we encounter a particular stimulus. Maybe you get a bad grade on a test. We are going to then have beliefs that are activated by that activating event. So we are going to have a belief system. So maybe because I got a bad grade on a test, I feel like a failure. Okay, what are the actual emotional consequences or emotional and behavioral consequences that are produced by that belief system? So I think that I'm a failure, therefore I feel worthless and sad. And then the important portion here is disputing and changing those belief systems, because that isn't a logical way to be thinking. So we want to start challenging those maladaptive emotions and behaviors. Getting a poor grade on a test doesn't mean I don't have worth. Maybe it means that I was sick, or maybe it means that I didn't enjoy the class and didn't study as much as I could have. So you start challenging, well, what's the problem here? Are you making defeatist statements? Are you assuming the worst? Are you catastrophizing? What's going on here that's creating this overly negative framing, and how can we change that? And so with this process, you would sort of slowly coax them to start changing those beliefs into something that's less maladaptive and more accurate and truthful to the reality of the situation. So getting a bad score on a test is probably not a good thing, but it's also not going to destroy your own self-worth. So we could find a middle ground between the two. And then similarly, Beck had his own cognitive therapies. And again, the focus here is on a lot of our irrational beliefs. But here, instead of having our A, B, C, D sort of structured process, here we would actually go through and focus on talking through the situation. Why are you feeling that way? What's driving this feeling? What's your logic behind it? Can we challenge that logic? So we have ideas that underlie a lot of these maladaptive responses. We're going to focus on those ideas, and Beck would specifically point out logical fallacies in the reasoning of the patient to force them to acknowledge that maybe the way they're thinking isn't rational. So we point out those errors in thinking. We're going to help them identify and then fix some of those thought patterns. And one of the reasons why this was so important is because many of these thought patterns are actually something that we don't consciously think of. So we might have an automatic response where I feel sad because of this event, but if we don't sort of break down why we're feeling sad, then it's really hard to change the thought patterns that are driving that. So Beck would focus on sort of picking apart why we're experiencing what we're experiencing, and then poking holes in that so that the logic would have to change, the reasoning changes, and then the behavior changes as well. Very, very similar, but slightly different in structure. So those are all of the talk therapies. There are a lot of different therapies here. Clearly, we don't spend much time on each of them, but that's how we're going to get through all of this for today. Next, we get to go into our behavior therapies. And no one should be surprised that this is one of my more favorite sections, mostly just because of experience with working with behavioral modification and teaching classes on behavior modification. So this is stuff that I've taught in other areas, which is pretty cool. But for our behavior therapies, we're starting to look at the idea that the maladaptive behaviors aren't so much a symptom of those cognitive processes or those unconscious processes or those past traumas or whatever else the other theories have framed it as. Here, we're saying that the behaviors themselves are the problem. We don't care why they're occurring. We want them to stop. So instead of looking at all of those internal processes, we are focusing on the external behaviors. So if we think back to our behavioral perspective, this isn't surprising. Behaviorists are all about the external environment, observable behaviors, responses to physical stimuli in our environment, everything external. For the internal processes, the conscious roles, all of that kind of gets swept under the rug and ignored unless we bleed into our cognitive behaviorism and find a mid-ground. But for most of the pure behavior therapies, it's all about how do we change these behaviors, usually by modifying external environments, changing up things that we're encountering. So the idea here is that our problem behaviors are things that we've learned. So we have learned that if we're in this situation, we can do that particular response. For most of the behavior therapy stuff, I think of, say, children who are acting out. That's where a lot of the literature I'm familiar with, where a child throwing temper tantrums, they've learned that if they throw a temper tantrum, they will get whatever it is that they're asking for. And so if you give in to that temper tantrum, they've been reinforced or rewarded for that behavior and are more likely to do it again in the future. So what we need to do is find some way to modify that behavior, to change it, so that the temper tantrum is no longer reinforcing, so that they have a different behavior that they would engage in. So the idea here is that we can use classical and operant conditioning as well as modeling to try and give alternatives or unlearn those maladaptive behaviors. So we don't want you to do this anymore, we want you to do this instead. we'll find that that redirection process is usually a pretty important component, because you can go through the process of saying, don't do this. But we run into an issue where if you tell someone not to do something, it's more effective if you give them an alternative to put their energy into instead. But yeah, we'll get around to all of that. So first off will be classical conditioning. So as a brief refresher for classical conditioning, this is when you would have talked about Pavlov. So classical conditioning is sometimes also called Pavlovian conditioning, but when it occurs, we typically have a biological stimulus, something that's occurring naturally that produces a particular response. So maybe you have something that scared you. So you fell off a ladder, and falling and getting hurt was something that caused anxiety and pain. So a bad situation. But because you fell off of an elevated place and experienced pain, now you've learned that high places are bad because they can lead to falling and getting hurt. So you can then generalize what you've learned to other high places. So maybe now standing at the top of the stairs is scary. So the idea here is that we're sort of transferring, associating something that actually happened or may have happened with something else, and we can share our response. So now we start experiencing anxiety in situations that were theoretically safe, but we anticipate that bad event happening over and over again, so it causes problems. This is typically how we'll end up with different fears or phobias. So for that situation, that might describe how someone came to be afraid of heights. So if we wanted then to help them remove that fear of heights, or at least reduce that fear of heights, there's a bunch of different ways that we can do that. One of these techniques is actually exposure therapy. So what we would say is we're going to introduce that person to what's effectively an extinction process. Usually in classical conditioning, what you would do is you're going to show them that that learned stimulus, specifically called a conditioned stimulus. So conditioned just means it's something that we've been trained on or learned about. So we'll put them in a high place and show them that you can be in a high place and not fall. So we remove or have an absence of our unconditioned stimulus. So we don't fall, and you show them that being in these high places doesn't lead to falling, and eventually being in that position and not experiencing the thing that leads to fear will help separate those two concepts in your mind. You'll reduce the feelings of anxiety that you're having, and it'll help you sort of calm down. You've been exposed to a situation that used to be scary, but you're realizing that it isn't tied to the event you thought it was, so those fear responses should lessen. So one of the big problems, and especially with a lot of our conditioning stuff, we have to be very careful, because if an individual is in that scary situation, their gut response is fight or flight. In a lot of cases, they're going to try and run away. And if we think about it and we use some of our classical conditioning terms, if they run away from a scary situation and they start to feel better, running away is something that was then reinforced. So running away becomes rewarding, which means that in the future they might be more likely to run away again. So if you're undergoing exposure therapy, you actually need someone who's specialized and trained in that to prevent things like that, because if they escape, if they run away, they're actually going to make the behavior worse. So this is one of those problems where you actually need a trained expert on this, because if you just try and do it yourself and you escape or avoid the situation, you can actually compound it and make it more problematic. So yeah, you always need to keep that in mind, and you have to sort of force yourself to sit in that situation until you can disconnect the link that we had learned between our conditioned stimulus and the unconditioned stimulus, between being in a high place and falling. But that actually does kind of apply to the next technique, which is almost like an extreme version of exposure therapy, which is flooding. And so flooding, the idea here is that you put that individual into that situation that they're afraid of at its highest possible intensity. So if somebody is afraid of heights, you are going to take them skydiving. If somebody is afraid of spiders, you are going to lock them in a room with a whole bunch of spiders. So you go from 0 to 100 all at once. And the hope is that you cause such an intense reaction and force them to sit in it and realize that I experienced the worst it could possibly be and I'm alive, that they no longer have that response to lesser situations. This one has a lot of ethical considerations, and it's actually very strongly discouraged. There are some special cases where some people have argued for it in, say, extreme situations, but for the most part, most people frown upon flooding because it has that tendency to cause a lot of distress. And again, if you're causing lots and lots of distress, they're a lot more likely to try and run, which can make it even worse in the long run. So flooding is one of those things that used to be used more often and has grown very strongly out of favor. Another sort of variation upon this would be something called implosion. And so implosion is basically getting the concept of exposure therapy, but without physically being exposed. In this situation, you could actually have imagined scenes. So instead of getting them to stand at the top of the ladder, you'd say, imagine that you're standing in a high place. So it's a lot less direct, and sometimes you can combine it. So you might start with imagined scenarios and work into real world scenarios, but this would be a much less intense version of this. Oh, perfect. I should have actually looked at my next slide, because the process that I was describing where we work from sort of low level exposure up to more intense exposure, the proper name for it is actually systematic desensitization. So for that process, since I actually have a slide on it, I can talk about it more. In this situation, we're combining a relaxation process and exposure therapy in baby steps in order to get people to tolerate situations that caused extreme anxiety. So in this situation, what you typically do at the very beginning is you'll sit down with a therapist and they'll give you what's called a SUDS evaluation. I can't remember what it stands for because I'm really bad with acronyms, but basically you're looking at your situational evaluation of intensity in terms of your response. So if we're scared of heights, we would say, okay, what's something that's not super scary? It makes you a little bit nervous. And so maybe you're okay standing on a chair because you've had to do that a couple of times and that's not too bad. So you would have a very low score for standing on a chair. But we'd say that standing on a bridge over a very high gap would be a really high score. And then we'd find something that falls in the middle. And so we'd find a bunch of points from the very bottom, low levels, to very high levels, and we break it into manageable chunks. And we would say that, okay, so what we're going to do is we're going to start you at the bottom. We're going to start at something that's not super anxiety inducing. We're going to get you to think and sit and be in that situation. We're going to go through relaxation techniques. We're going to slow your heart rate. You're going to tell yourself that you're fine until you can be in that situation and not get worked up. So we start at that low score, and then once you can sit and relax and be comfortable, we'll work our way up to the next step. So something that's more intensive. You're going to sit, you're going to think, you're going to force yourself to relax until you can sit in that situation and be comfortable, and so on and so forth. And so for this, usually it requires multiple exposures because re-encountering that situation can cause you to get nervous. But if you have sort of repeated exposures to that, it can help reduce that automatic response.